Assalamu alaikum, the clinical day. The role, you are the senior health officer in the rheumatology clinic. The scenario, Mr. John Adam, 55 years, referred to the clinic with the complaint of back pain. Please sit with Adam, examine him, and address his all concerns.
Okay, start Dr. Bassem.
Okay. I will share the timer just a while. Okay. You can start. Here
Hey,
you
good
go.
morning.
Good morning.
Good morning. I'm Dr. Musa, doctor in the clinic today. Sorry, in the ward today. Let me confirm you are Mr. Adam, 52 years old.
Yes, doctor, I am.
Okay, Mr. Adam, brought to my knowledge that you have back pain. Could you tell me more about this pain, please?
Yeah, doctor, I have this pain for the last 4 months. It's on and off, and I tried the medication, but it doesn't help.
I am sorry for that, Mr. Adam. It is the first time you have this pain, Mr. Adam, or any previous pain?
Yeah,
Before
first
4
time.
months, first time. Okay, sorry for that. Mr. Adam, you feel, or you have any morning stiffness in the back pain?
No,
Okay, did you notice anything that improve your back pain, like rest or movement?
actually, doctor, when I have rest, I feel the pain more.
No, okay, I'm sorry for that, Mr. Adam. Can I know, Mr. Adam, where is the site exactly of this pain?
Yes, it in the lower part of my back.
In the lower back, okay. Mr. Adam, can you describe me the nature of this pain? Is dull aching or sharp or burning?
It's like dull aching one. I feel also limitation.
I'm very sorry for that, Mr. Adam. I hope we help you. Okay, Mr. Adam, this pain goes to anywhere?
No, doctor.
To your shoulder. Okay. Any specific time, Mr. Adam, increase in the night or increase in the morning?
It's worse in the night, doctor.
I'm sorry for that. Mr. Adam, how much you rate this pain? 1 is minimum and 10 is maximum. How would you give this pain?
Yeah, from 5 to 6, doctor.
Okay. Mr. Adam, do you have any blurring of vision?
No.
Any shortness of breath?
Yeah, doctor, I feel short of breath sometimes.
When it started exactly, Mr. Adam?
Yeah, 2 months back.
2 months. Okay. Any flip? Any flip?
No flame, doctor.
Do you have any cough?
Yes?
It is dry or have dry cough? Sorry. Yes.
Yeah, it's dry one.
Okay. Are you have any? Are you aware about you aware of your heartbeat? Any
Yeah,
reason?
sometimes, doctor.
Sometimes. When it started exactly?
The same duration.
Okay, Mr. Adam, do you have any flu urine?
Yes, doctor, I have this.
Okay. Do you have any leg swelling, Mr. Adam?
No swelling, doctor.
No swelling. Okay. Mr. Adam, do you have any weakness in your limb? In your
No,
leg? Sorry.
no, no,
Any numbness in your leg?
no.
What about your water work increase? Any change? Increase in number, increase in frequency or amount?
Only the frothiness.
And the frozeness. Sorry about that, Mr. Adam. Any loss of control of your water work?
No,
Mr. Adam, do you have any loose motion?
no,
Any bowel changes like constipation?
no, doctor. It's normal.
Okay, Mr. Adam. Mr. Adam, sorry, just to confirm, you have leg swelling, yes?
Yes. Leg swelling? No, no leg
Yeah,
swelling.
no leg swelling. Okay. Okay, Mr. Adam, do you have any problem in your vision?
You asked me before,
Blurring of vision?
doctor. Now, no.
No. Okay. Okay, Mr. Adam, do you have any long-standing disease should be aware?
No, doctor, I don't have.
Okay, do you have any family history of any gland problem or blood problem?
Yeah, my mother was having the rheumatoid arthritis
When she was having rheumatoid arthritis?
when she was in her 30s.
Arthritis, okay. Mr. Adam, what's your drug list, please? Do you take any drugs?
I take paracetamol and also profane.
Okay. Any over-the-counter other than paracetamol and ibuprofen?
No, doctor, only that.
Okay. Mr. Adam, do you have any tummy pain?
No,
Any heartburn as a brush?
no,
Any bleeding from any orifice?
no,
Any black stool?
no.
Okay. Do you have any joint pain?
Yeah, sometimes, doctor, I feel in my hands some pain and also in my neck.
Okay, sorry for that, Mr. Adam. Is there in the joint pain has morning stiffness?
Yes, doctor, but it's not long time.
Okay. Okay, Mr. Adam, do you have any rash in your body?
No, doctor.
Okay, any burning in your outer work?
No, only the frothiness.
Okay, Mr. Adam. Sorry, Mr. Adam, about the stiffness in your joint. For how long you have morning stiffness?
Less than 30 minutes.
Is that- Okay. Um, okay, Mr. Adam. Any weight change
No,
because of weight? Any fever?
no,
Any change in your appetite?
no.
Okay, Mr. Adam, can I examine you, please?
Yes, sure, doctor.
Okay. During examination, I will ask you. Okay, Mr. Adam, I need to see your back.
Okay, what you want me to do, doctor? Just tell me and I
Uh,
will.
okay, I need to stand
Okay,
and do your neck in the right, and then to the left, and then to the front, and into the back. Is there any
okay.
limitation?
Yes, there is limitation.
Okay. Then
But
I will.
how you will see all this? You ask me to stand, right?
Yes, to stand. Yes.
Okay. You want to do something else
Uh,
before doing this tests, this steps?
uh,
Okay, go ahead, continue.
Okay, then I will ask him, Mr. Adam, to forward to his hand in the knee.
Okay,
Uh,
there is also limitation. He can't reach.
there
He
is
cannot
only
reach.
okay. I need then to move right and left to examine the lumbar vertebrae.
Again, limited.
Again, limited. Okay, I will need to see the back if there is any kyphosis or limited lumbar or decrease absence of lumbar lordosis.
Okay, how you want to see it?
Kyphosis in the upper back. He will knee his head.
Okay, you how
Uh,
you start it and how you can see it. Patient is standing in front of you. You want to tell
the,
him something to do before you.
no, no. I will see only the kyphosis and the loss of lumbar lordosis.
Okay. So what instruction you ask me now? Just stand and you will
Just
see.
stand, and I will see the kyphosis and the loss of lumbar lordosis, and then I will do a Schubert test. I will ask the examiner if I need to do Schubert test. I will mark.
Okay, tell me the steps. Yeah.
Okay, I will mark between the posterior intertuberosity
Mm-hmm.
in the between, and move down down 5 centimeter and above I think 5 centimeter, and then ask and mark between the two markers between yes, and then I will ask Mr. Adam to knee if there is a limitation less than 5 centi. Sorry, the distance now is 10 centimeter. If
10
there is
above and 5 below. 10 above and 5
yes,
below.
10 above
Okay,
and
then
5
yeah, you will put 2 marks. Then you ask him to bend forward.
to bend
Okay,
forward. Okay,
okay,
if
yeah.
there is no increase more than 5 centimeter, it will be positive. Yeah, so the increase only less than 5 centimeter. It
Okay,
will
so
be
total
positive.
total of increase how much supposed to be? 15?
Uh, when stand 15, and
Okay, when he bend forward, it will be?
more than 20 in the normal
Yes, in the
patient.
normal, yes, 21. Okay.
Um,
Okay, positive. What else you want to examine?
Okay, I will ask Mr. Adam. I will stand with my back in the wall and ask him to stand like me and tell him to try to move his occipital back so there will be distance more than 5 centimeters. It will be positive.
More than 5 centimeter. Okay. So
Occiput test. Yes.
yes, it's occiput wall test. Okay, what else?
Yes. Then I will.
It's positive,
I
yes.
Okay. Then I will do measure. I will measure the chest expansion. I will expose his clothes and measure the chest expansion between. I will in the nipples and ask him to take a deep breath. If there is limitation less than 5 centimeter, it will be positive.
Okay. Well,
That's,
this is
that is
expansion. What else?
that is the expansion. Okay, then
There
I
is
will.
limitation in the right side.
Okay, then I will examine the eye if there is any redness or anything. Then I examine the chest for any fibrosis in the upper loop. I
Okay,
will
no redness in the eye. Now you went back to the chest, right? Okay.
yes, the chest. I will do chest expansion by my hand,
Okay,
and
you
then
finished the expansion. What
yes,
else?
I will do auscultation in
Okay.
the upper chest if there is any fibrosis, any
Okay.
fine basal crepitation
There is crackles in the right apical side.
in the
Right?
right.
Yeah.
Okay,
Right apical zone.
okay, I will ask Mr. Adam to cough.
Yes.
Okay, if the fine basal is still present.
So you will auscultate him again? No,
Yes.
it's not disappeared.
Okay, sorry for that, Mr. Adam. Okay, I will auscultate the base of the lung for any
Okay.
fine basal crepitation.
No
Okay,
crackles.
then I will auscultate in the left in the second aortic area, in the left third intercostal space for any murmur,
Or what?
aortic regurg,
Okay.
diastolic murmur. When he will stand and take a deep
Stand?
no مش not stand sit
Yeah, sit forward.
sit forward and
Okay.
take deep breath and expiration.
Okay.
I will listen to the murmur.
Okay.
Okay, then I will examine the kidney for any development.
Perfect. Okay. There is
Uh,
multiple kidneys.
there's movement. Okay, then I will examine the lower limb for any swelling, and also I will look for the back of the knee. Mr. Adam, do you have any pain in the back of the heel?
Yes, I had before, doctor.
Oh,
It was before.
okay,
But now you didn't find any redness. Okay, what else?
okay. Uh, oxalate. Um, um,
2 minutes left.
okay, Mr. Adam, do you smoke?
Yes.
Okay, I advise you, Mr. Adam, to stop smoking because it put you at a risk. So I advise you to stop smoking, and I will refer you to smoke cessation clinic if you would like.
Okay, doctor.
Mr. Adam, do you drink alcohol?
No,
Okay, what's your job, Mr. Adam?
I am bus driver.
Okay, so it's impact in your symptom impact on your daily activity and on your job.
To be honest, doctor, I can't see the mirror. I cannot see the
Yeah.
mirror.
Yes, Mr. Adam, I will refer you to also to occupational health care worker to help you about this issue. Um, mm,
1 minute left.
okay, Mr. Adam, do you have any concern?
Yes, doctor. What happened to my back? Is it rheumatoid arthritis like my mother?
I really appreciate your concern, Mr. Adam, but I think rheumatoid arthritis is unlikely in your condition, but you have another defense system, which is called ankylosing spondylitis. It is also a disease of defense system which attacks your back. I will we will go what are going to do some investigation and some scans in your back, and also we will refer you to occupational healthcare worker, and also our um, joint doctor to give you full care and management plan. In other concern, Mr. Adam.
Is it something serious, doctor? And why I have short of breath?
Yes, I should suppress that you have scarring in your lung. It is one of the complications of this disease.
Okay, time is up.
Okay.
The examiner questions, what's your case about?
Okay, this gentleman presented me with a back pain. This back pain increased at night and increased during rest, improved during exertion and throughout the day. This gentleman has limitation in his spinal cord spinal cord movement in cervical and thoracic and sacral limitation. It is positive oxybate test when I do it, and also positive sugar test. And there is decreased chest expansion, and biosculptation. There is fine basal crepitation in the upper loop, no change with cough. And also there is past history of pain in the back of the heel, but now improved. So my نسيت. So my diagnosis will be ankylosing spondylitis.
Okay. What investigation you want to do?
Okay, I will, apart from basing investigation, CBC and liver function test, and also kidney function test, looking for protein in urine, for proteinuria. Patient has fluorescent urine. And also I will do X-ray to the chest, and also looking for reticulonodular shadow, and the CT looking for honeycomb appearance, and also pulmonary function test and transfer factor. It will be restrictive pattern, FEV1 divided by FEV. It will be more than 70, and with the decreased transfer factor. Also, I would like to take acid fast bacilli to this patient because he has fibrosis, and I will do ECG and echo.
Why acid fast bacilli?
For fibrosis?
Any history of travel?
No, no.
So unnecessary test. What
Yes.
else?
Okay, for confirmation, I will do genetic test HLE 27, and also I will do inflammatory marker, and I will do X-ray and CT X-ray and CT X-ray and MRI in the lumbosacral area. It will show bumbo sign by X-ray, and the MRI is the gold standard to see the sacroiliitis, and also protein in urine.
Okay, what bedside test you want to do in this patient? If I ask you, name 3 tests, bedside tests you can do.
Okay, for back pain?
In general, for the whole condition.
Okay, for condition, I will do urine dipstick for proteinuria.
Perfect. This is one. The second?
The second, I will do ECG.
Perfect. And
Looking
the third?
for aortic leakage or EV conduction delay.
Perfect. What else? The third?
Third, I don't remember, Dr. Bess.
Spirometer?
Spirometer, yes, spirometer.
Okay. How you manage this patient?
Yes, this patient I will do multidisciplinary team from rheumatology and nephrology and also pulmonology and also cardiology. It will be by non-pharmacological, by education and counseling of about his disease. and also regular by regular exercise. I will refer him to exercise training program.
What
Uh,
specific exercise he should do?
Stretching test like swimming.
Okay, so hydrotherapy.
What to best hydrotherapy?
Hydrotherapy, yes. Okay.
Mm.
What other important advice?
Uh, Important advice. I don't know.
What's his job?
Yes, stop.
Okay.
I don't know.
Stop driving. Yes, he asked you, I can't see the mirrors.
Mm.
Will you
Yes,
allow him to drive with,
because there is kyphosis. Yes.
yeah, limitation of the neck movement?
Mm.
Okay. And the pharmacological therapy.
Pharmacological, it will be part non-steroidal, like ibuprofen and also paracetamol. And if there is any joint pain, I will give him, I think, methotrexate. And if no response, I will give him biological after exclusion of hepatitis B virus and hepatitis C virus and HIV and TB.
What biological you know for ankylosing?
I don't know.
Okay, what's the differential? Last question. What the differential diagnosis in this condition?
Yes, the professional, I asked about the rash, but I didn't check his hair
For what?
for psoriasis.
Excellent. And you didn't check the scalp, right?
Yes, I didn't think
Okay.
self. I
Okay.
forget. Yes.
So this is one. The second.
Yes, the second, it will be enteropathic arthritis. I asked him about any loose motion,
Okay.
but no loose motion. Also, the fourth, and it will be
Yeah,
maybe
one more.
reactive arthritis.
Okay.
Uh,
Did you ask about any the urinary tract infection or about his
mm,
sexual habit?
no.
Okay. Time is up. You know why I brought this case, right?
Yes, it is long case. Yes.
Yes, with good and with the long examination.
Yes.
And you have to do the full steps of examination plus the history. You were reluctant. I don't know why. You were reluctant to start and you were reluctant also to finish the history. Like you, I got the case, but you didn't finish the association. You didn't finish the differential. Even after the examination, you didn't do it in the examination.
Yes.
Specifically, this case for you for the exam purpose. They want you to do everything in the exam. So what you have to examine in this patient to start with. Let's review the steps again.
Yes. Yes, doctor.
Okay, you saw the patient for first time. What you ask him to do?
I think you do start with the eye if there is any
No,
vision.
he has
What?
back pain.
Yes, yes, yes. Ask him to
Okay.
walk. Yes,
No, not walk.
not
First
walk.
thing, expose your all back. I ask you this step many times. What I do, doctor? What you want to instruct him? You didn't give me this instruction. And by the way, they can minus you a very bad mark in this
But
because
really,
how
Dr.
you.
Bassem, I will ask him to suppose. Really, I will.
Yes, you will, but
Mm,
you might also forget. If you
Yes,
didn't do in the training, you might forget.
yes.
How you will know the lord back of the loss of the lordosis, back lordosis? How do you know it from the clause? How do you discover the scoliosis or kyphosis if you are not exposing the back? You will never see any of them, right? I know you can do it in the exam, but be sure that you will do it. I want to be sure that you will do it. I ask you what you will do, what you will do. Plus also do as you are in the exam. Please, if you feel pain, let me know. If you
Mm,
feel my hand cold, let me know because it's cold weather now. Please train on this word if before examining any patient. You might touch him and he will say ah, and it will affect your welfare. Okay, it's cold weather
yes,
now. Take care of
yes.
this, and also the stethoscope. It might be cold, and he will be of
Mm,
course warm because he's wearing a lot of clothes. So introduction. I will examine you today now. Please, if you feel any discomfort, any pain, let me know. And just Also, my hand might be cold. Please, I will try to warm them, but it might be still cold because it's cold weather. Even if he say, you give him the warning. Okay, this is for the welfare. This is the introduction. Please, can you unwear your t-shirt for the back and start to inspect? And you can ask him where is the exact site of the pain, and you'll examine the area of the back pain. Okay. Then after that, you can let him stand to do the specific test for ankylosing. Can you please stand up? Yes, doctor. First, can you stand up to the wall and do the occiput wall test? Okay. You can touch the wall, but he will never touch the wall. So it's not 5 centimeter. Yes, it's more than 2 centimeter. It's a diagnostic. Normal person can touch the wall. If you stand to the wall, you can touch the wall. But if not touching the wall, this is a diagnostic. But it will be also more than 2 centimeter. Okay, this is for occiput wall. Then you will ask him, please copy my movement, as you said, all direction and both sides, and touch your knees. All this you can do. Then modified Schuber. Please, can I use a tape? If there is a tape. What you want to do? I want to do modified Schuber test. 10 centimeter above and 5 centimeter below. Can you bend forward? It will be less than 21. This is another test. You try to finish all these things while he stands. Okay. Then you can sit him, ask him to sit down, and start examining from the peripheral, as usual. The hand. What you want to examine the hand?
Yes, the joint, he has
Okay,
joint
joint.
pain.
What else? What else?
Proximal myopathy.
No, in the hand. I didn't go to the proximal nerves. Hand. You said psoriasis, right? It's a good
Yes,
differential. So you have to examine the nail.
nail biting, yes.
Yeah, examine the nail. What else after the nail and the hand? What you will examine?
Uh,
Peripheral.
Eyes.
Pulse. Pulse for,
For
right?
EV reduction, yes.
Yes. The pulse as a character and the pulse as volume. You will have both of them, either bradycardia or you will have hyperdynamic circulation or collapsed pulse, right? Aortic regurg. He had it. He told you.
Yes,
Okay.
yes.
So be systematic, otherwise you will lose a lot of things. You lost the pulse and the pulse volume. Okay, then the face. You went to the face. What you will examine the face?
The eye,
Before
acuity
eye.
and fundus.
From up down. Start always from the
Yes,
head till the
the
toe. What
scalp
in the
for
head?
psoriasis.
The scalp. And if she's female, you can ask her to examine behind the ears. It's very important. Okay, for or hairline, scalp hairline, for psoriasis. Okay, you finish that. After this, what? The eye.
The eye.
Okay, what you will examine the eye?
But he told me no bleeding vision, no eye pain.
But
So
you
I
have to
can,
examine for anterior uveitis
yes,
still.
yes, the eye acuity and fundus.
You can offer the fundus, but it will not affected. It will be affected only from anterior uveitis outside any redness and pallor as well. But it will not be there. He doesn't have it now. Okay, what else after that? Now you go
Any
to the
any any rash around the eye for
no,
dermatomyositis.
no. This is seronegative. No,
Mm.
don't overthink. Okay,
Okay, the
this
chest
is
and then the chest.
seronegative. Okay, the chest. Start step by step from the chest in the neck before the chest, the neck. What you will examine the neck?
Trachea, trachea
GVP,
and GVB.
GVP. Sit the patient and let him in 45 degree. Press. Are you have any pain here? So I'm making it long and details, but this is for you. Okay, for your exam. Press on the abdomen and check for the GVP. It might be there. Then now you examine the chest. If you want chest as a chest or heart, the chest do it in the back. That's enough and more than enough. The heart from the front. So don't examine the expansion from anterior and posterior. You don't have time for all this. Do one step only at the back. So let's start by the chest examination. You want to examine for the expansion, as you said. Of course, you have an inspection first, any scar or any limitation from outside. I mean, by the movement. If you want to examine it while standing away from the bed, or you can do it after sitting behind the patient. Then you start the expansion. Okay, can you please have a good breath in and out? Then you will have to check the expansion. It will be limited. By the way, expansion, you can observe it from the end of the bed, okay? Because it will show you asymmetry for chest rise. Let's go to the percussion. Will you do a percussion? Even two sides only, up and down, or upper or lower, upper and lower. Okay. Then auscultation. Crackles. Can you cough, please? Okay, cough. Disappear or not? So this is fibrose. Now you'll go to the front. What you will examine the front? You said it. Do you think the apex beat important here?
Sure, aortic regurg.
Yes, so it might be displaced. You can either just show the
Mm.
examiner that you are trying to detect the apex, and now auscultate for the aortic regurg as a murmur. Sit forward. Can you take the breath in and out and hold and auscultate? Then abdomen for amyloidosis, kidney pollutable or pollutment of the kidneys. This is the third or fourth A. Then the Achilles for Achilles tendonitis. And you can also pass by the kidney, by the knees. Examine the knees for any crepitus if you have time. Leg edema and finish. What's your concern?
Mm.
Just be
Yes.
systematic. They are commenting even about the steps of examination and systematic examination. Okay. Let him stand first and do the tests for closing while standing. Then when he sit in the bed, do the other examination. But don't miss the specific examination for closing. It's very important. Okay? And expose him. Don't forget.
Mm.
Sometimes they are giving instruction, don't remove your clothes. They are waiting for you to tell him, can you? Then they are minusing you because you didn't tell him to remove or to unwear his t-shirt or to expose his bag or whatever. Okay?
Yes, Dr. Bess.
Okay,
Very good.
so
Really, I have defect in this case. I will ask you for this case. I have many questions for this
mhm,
case. Okay.
yes.
First, about reactive arthritis, I will ask him any discharge from water work.
Any infection even, it's enough. Any infection in your water work. Do you have any
Infection.
casual relationship? You didn't ask all this because you start examination, but while doing the examination, you can ask, right? You can ask. I can ask you some question while, but you remember at the end the smoking and alcohol. But don't forget
Okay.
the reactive. Okay, what
Okay.
else?
Yes. If the patient has red eye, pain, discharge in his eye, what I will examine? The acuity and the fundus only
And the redness by torch.
by torch. Yes.
Yes, by the way,
Um,
you have a torch. Also, take torch with you better. They will not provide torch.
so okay. The third question: if the patient has redness, has uveitis, and the patient is concerned about what about my vision, will be returned back or not?
And so I will. What's the answer? What do you think? How you answer him?
I think we will give him some eye drops,
Yeah,
but
you are the one giving him, right?
yes, but it is progressive disease.
So you are the
Uh,
one giving the medication, or you will refer
no,
him?
yes, refer him. Yes.
Be simple and don't complicate the case. If he asks you, I will refer you to the eye doctor and he will address this concern. If you don't know, even it's a
Mhm.
concern, you will get the mark and you are a safe doctor,
Mm.
right
Yes,
or no?
yes.
Be
But
simple and think about your role. You're not ophthalmologist to answer him and to give him medication or tears or drops. But knowledge-wise, I'm not sure what will happen really. Is it reversible or reversible? But it's on and off, I think, so it's reversible. It might happen and resolve. It's not something irreversible. You got it?
yes, Dr. Bess. Very good. Very good case,
What
really.
else?
I need it. I was need it.
By the way, if this case came to you in the exam, it will be a gift.
Yes, Doctor.
Wallahi. You will get
Really, really, I expect this case in my exam. I expect.
And this is your performance now.
Yes,
Please,
sure.
please do it well in the exam. I don't,
Inshallah.
yeah, I don't want any half mark to be minus, okay? Because you did everything, but still unsystematic. And now you know how to do without wasting the time. The time also will help you in the exam, inshallah.
Inshallah.
Okay. Any question?
Oh,
So the evaluation you want, the physical examination, you will take, I think, borderline and
borderline.
identify also. Because you miss a lot of things like the pulse, the volume. Although you ask about the kidneys and the Achilles tendonitis, the aortic gauge, but I want you to be more systematic. This is for the physical examination, identify the finding. Clinical communication, you didn't ask about other differential. However, you give me the differential. So the differential is good. You can get full mark in the differential, but the clinical communication still borderline because you miss others.
But I ask you, Dr. Basim, in the history, are you have any rash?
Okay, so the rash
but
for what?
must fight.
The rash for what?
For
Seronegative?
psoriasis.
Psoriasis, but they're reactive.
Yes, reactive, I forget. I
Yeah.
tell you. Yes, doctor.
Yeah. You write the differential in your paper and ask one by one about the differential.
Yes.
They care about the things, the examiner. Okay, then the welfare, okay, and also the concern. I think the concern you didn't finish the concern, but you answer me. So you have missing or two borderline in the physical examination and identify the finding. Please improve them in the exam.
Dr. Basim, about
Yes,
the concern. Yes, Dr. Azhar, go on. How are you?
Alhamdulillah. How are you, Dr.
Yes,
Mahmood?
doctor. Yes.
Mashallah, you did well in this case. Mashallah.
Thank
And
you,
you
Dr.
look to
Azhar.
me very confident.
Thank you, Dr. Azhar.
Inshallah, inshallah. I
Inshallah.
hope that this case will be in your exam. Inshallah.
Inshallah.
Dr. Basu, I want to know why amyloidosis in reactive this ankylosing spondylitis.
Yeah, it happened with all this chronic disease. It's association. You remember the 7A's?
Yes, 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 yes.
Yeah, ankylosing amyloidosis is one of them. 7A's.
Yes, 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 yes. And
Okay.
one more thing I want to ask.
Yeah.
Ankylosing spondylitis, usually it's presenting less than 40 years. Their age was
No, no,
52.
no. It can persist. Start early, but it persists.
But the history was only 4 months.
Yeah, it maybe he had before, but it will be symptomatic more in this age. But I put it like this. It's okay. It will be in this age. You saw many people. I can see many people. They have the same question mark position, and I think I can diagnose them from the first as a spot diagnosis. They are old also. They are not young. You got it? You can see
Dr.
most of
Mahmood,
this. Yes.
and I have some questions for you for this scenario. If the patient is having only back pain without peripheral joint pain in ankylosing spondylitis, will you give any DMARDs?
No,
If
back
only
pain.
back pain and no peripheral joints.
Back pain.
Yeah. Perfect.
Yes.
Yes.
Yes. Non-steroidal. If not improved, we will move to biological direct.
Perfect. Yes.
I think
Very
that.
good, very good.
And what
If
biologically,
only,
you know? Yeah.
and if only back
What
pain without peripheral joints, only you will not give
Yes.
DMARD.
Yes.
And peripheral joints are involved,
Yes.
then what you will give? What is the name of biological agent?
Yes.
At
Perfect. Good
least one name
question.
you should know.
A for A also. Another A. Remember the A.
Yes.
Mahmoud.
What is the name? Sorry. What is the name? Sorry,
Yeah,
Dr.
of
Basim?
the
What is the name?
biological. What the biological? Yes. I told you starting by A
Yes.
letter. What is it?
Adalimumab.
Yes.
Yes.
Adenomab. Etanercept also still there. Yes.
Or infliximab also may be used.
Yes.
I think
Dr.
adalimumab for the back involvement for the axial. Is it right? I think for the peripheral arthritis we use like rheumatoid arthritis methotrexate, isn't it?
Yes, we are saying that.
Yeah.
Methotrexate in the peripheral only.
Yes. Okay. I want to add few points.
Yes,
I
Dr.
think Dr. Mahmoud, did you ask about trauma, fall, loss of
No.
control of sphincter.
But yes, I asked about
Yeah, he asked about
compression
the bowel
symptom,
and the control. Yeah.
but patient has inflammatory.
But I think it's
So
important to rule
yes,
out trauma
back pain,
and fall.
yes.
Yes, and in this scenario, they ask about mention 3 causes for renal impairment in this case.
Yeah, perfect. I also
Yes.
mentioned it in the history. Good question. Yeah. Answer.
Yeah.
Yeah.
Yes, nephrotic and right side heart failure and amyloidosis.
Amyloidosis is one,
And
And right side heart failure.
not really.
not direct. Yeah, not direct.
Not direct. Yes, not direct.
From pulmonary hypertension.
لا,
Okay, think about something direct.
Yeah.
Direct to the kidney injury.
Sorry, lower limb swelling, yes?
No.
Renal impairment. Causes
Renal
of renal impairment in
Yes,
ankylosing
because
spondylitis.
maybe
And
because
say-
of non-steroidal. Yes.
Yes,
أيوة
perfect.
صح. NSAID induced amyloidosis and IgA nephropathy. IgA nephropathy is forgotten by candidates. Is also one of the causes. And also this case, by the way, appeared in one of the centers. I don't remember which center, but it appeared as a case of peripheral arthritis, like the patient presented with hand pain only. And if you ask the patient any other joint involvement, the surrogate said no. So you have to ask specifically about back pain. Then if you ask about back pain, he will say yes for years. So you know it's peripheral arthritis associated with ankylosing spondylitis. You got my point? Don't forget it.
Yes.
And also check for pacemaker in the chest, palpate, because if they had heart block, they might have pacemaker and scar below the clavicle.
Clavicle.
Yes.
Yes.
Good.
Yes,
Thank
this
you,
case is
Dr.
appearing a lot these days. I
Yes,
remember
I expected in my exam would be ankylosing spondylitis. I expect. Really?
Yes. I remember in this diet, the last diet, I practiced it with one of my colleagues, and just few days after she got it in the exam. And they asked a lot of questions. They asked about all the A's, the associations with the ankylosing. So make sure to memorize them and yeah.
Yes.
Thank you, Dr. Ryan.
Yeah, thank you, Dr. Ryan. It's good to know. And also the correlation with the questions related to the renal failure. Be ready for all this question if it's the case in the exam. It's you know why it's a case of exam, because a lot of finding you might have and you might miss. They like this type of cases to find and to pick up a lot of things, and sometimes there is findings not related and you might miss them. I mean, not related to the examination. So the back pain, what do you think you will miss the Achilles tendonitis? Yes, you can miss it if you are not consider it in the examination. So they might minus you and they will write in your paper, he missed that Achilles tendonitis. And the patient was having, for example, leg pain. They like such type of cases to pick up a lot of finding, and once you miss one of them, they will minus you. And ankylosing spondylitis, one of these cases. It has a lot of finding from head to toe. Everywhere you can find and you can pick up a finding. Okay, Dr. Mahmoud, please don't miss. And also, again, don't recall. Let's record the 7A's started from the head downward. You are the one. Tell me.
Yes, anterior uveitis
Excellent.
and apical fibrosis,
Perfect.
aortic regurg,
Okay.
AV conduction delay,
Okay.
amyloidosis,
5.
ankle Achilles tendonitis.
Yes. I think. Did we miss any?
IgA nephropathy.
Yeah, IgA nephropathy.
IgA
Yes.
And
This is the,
sometimes
yeah.
and
This is the
sometimes
last. Yes.
to add peripheral arthritis as one of the A's, they write and peripheral arthritis. Just
Okay.
to remember that peripheral arthritis can be involved. Yeah.
Okay. Thank you, Dr. Ayan. IgA nephropathy and peripheral nerve. Yes.
Is the cause of palatable kidney is amyloidosis?
Yes, amyloidosis.
Okay.
Any question in the case? Any question, Dr. Mahmoud?
Thank you, Dr. Basim. Thank you a lot for this case.
I know it's a repeated case, but I brought for you because the
This case will come to me in the exam, Dr. Basim. I am sure.
Okay.
I am sure.
I hope you will do more better and perfect as a performance, and you can do it.
Mm.
Just please be systematic. Don't go down and go up again. Finish everything
Yes.
in place and on time. The eye and the head, finish them together. The hairline, the eye, and the neck, as I told you, step by step. And before all these steps, let the patient stand up. If you want him, by the way, he can walk, but I think it will not be impaired, as you know. Nothing will be there unless severe sacroiliitis. You can ask him to turn around. It might be like moving one piece. Severe sacroiliitis.
Because Dr. Basim, I expect the scenario in my exam next Saturday will be difficult of walking. So, so I told you first.
Difficult focus, and the patient case will be ankylosing.
Ankylosing, yes. I expect that.
Okay, can be. Any question before? Can you write the case for me, or any question or comment by others? Yes, please. Go ahead. Any comment? A lot of comments in the chat box. I will read.
Dr. Mahmoud, just one comment. This patient I told you about, the case that appeared as a case of peripheral arthritis, the patient was limping, and they asked, why is the patient limping? So,
Achilles.
yeah.
Achilles tendonitis, yes.
Yes.
That's
Okay.
why I don't forget Achilles tendonitis. I asked Dr. Basim about Achilles tendonitis.
Yeah, good question it was.
Yes.
Yes. Thank
This
you.
case,
Mr.
yes,
Raya.
Dr.
Dr.
Basim.
Manoj, I have one question for you.
Yes.
Maybe it will help you in the exam. Patient presented with backache, and he's also having weakness of dorsiflexion and inversion. What do you think? Where is the lesion?
Weakness in dorsiflexion and
inversion.
Dorsiflexion and inversion.
Inversion inside. Inversion.
Inversion
Yeah.
inside.
Weakness of inversion, weakness of dorsiflexion, and patient also having back pain. Maybe
Perfect.
spot dog. It may come as a short case.
Yes.
Where will be the lesion?
It's in L5.
L,
Common
L5.
boronial
Very good.
or
Yeah,
L5.
peroneal.
L5.
Yes.
L5. L5.
L5. Common boronial is not inversion, only inversions.
Yes. And common peroneal nerve, how it will present? What is the difference?
Foot drop.
So
There will be no back pain, weakness of dorsiflexion, and weakness of eversion.
Yes.
again,
So
sorry,
please,
Dr.
this case may come as a foot
please.
drop. Huh? If
Again,
there's a common peroneal nerve lesion, there will be weakness of dorsiflexion and eversion. And if
okay.
there will be no back pain, there will be no back pain. But in case of L5, the patient may have back pain and weakness of dorsiflexion and inversion.
Mhm.
So the
Okay,
difference in
examiner may
inversion
ask
and
you.
eversion.
Yes, both
Examiner may
inversion
ask
and
you,
inversion.
in the case of uh, peroneal nerve, if only there's a loss of sensation between the first and the second toe, and the rest of the foot is normal, what do you think? It will be superficial branch or deep branch?
Okay. Okay.
Superficial.
If there is a loss of sensation between the first and the second toe, and rest of the dorsum of the foot is normal, it will be the superficial branch of common peroneal nerve damage or deep branch. Deep branch will be damaged. Deep branch will be damaged because deep branch only supply to the first and second, and the superficial branch it supply rest of the dorsum. So this question, a foot drop may come in the exam.
Okay.
Mm.
This is as a short.
Yeah,
Yeah.
as a short, as a short.
Yeah. Yeah. In
And
the
the
nerve.
treatment
Yeah.
will be, and he will ask you how you will
Physiotherapy.
investigate.
Yeah.
Investigations will be
MRI.
EMG nerve conduction study. Yes.
nerve conduction, the EMG, and if you want to do sometimes ultrasound of the nerve, sometimes, but EMG and nerve conduction very important. treatment will be physiotherapy, occupational therapy,
Yeah.
neurologist,
Physiotherapist.
specialist nurse, and then AFO, ankle foot orthosis. If still not benefit, then we will involve the surgeon only.
Yes. Thank you, Dr.
And the
Azhar.
differential
Okay.
diagnosis L5 with common peroneal nerve.
Yeah. L5 as a radiculopathy.
Radiculopathy, very good.
Yes, yes. But the difference will be in the inversion. In the L5, Mahmoud, it will be weakness of the inversion.
Inversion, yes.
Yes, but
Inversion.
yeah, peroneal outside, so all outside will be affected, like
Yes, and the
eversion
foot
and
drop, Dr. Bassem, will
and
be
foot drop. Yes,
yes, peroneal. Yes,
peritoneal. Yes, because
yes.
peroneal give the dorsum muscle of the dorsum, eversion and dorsiflexion. Once it's compressed or injured, it will be foot drop. Thank you,
Thank
Dr.
you.
Azhar.
Thank you, Dr.
Yeah,
Azhar, really. Thank
yeah,
you.
you have a lot of gifts today, Dr. Mahmoud.
I
All
need
the
it.
special for you.
I need it, really, Dr. Bassem. I need it, really.
Inshallah, best of luck. Okay, I will try quickly to read the comments. History about back trauma. Yes, Dr. Mahmoud, remind you, Muhammad Mustafa. You have to ask about trauma and respiratory. Yes, you can ask more about respiratory symptoms. Ask a specific question about examining the eye. Yes, advice about driving. Sure, the back pain, inflammatory origin, worse in the morning. Improve after 1 hour. Should be like that in ankylosing spondylitis. Whenever a patient is resting, yeah, the pain is started, and it will not subside unless he move. So the worst, yes, as you said, in the morning, but it starts with the rest, and it takes time till be resolved. With morning,
So what
yes.
should be the exact time? It should be 1 hour or
No,
45
no.
minutes or more than 1 hour.
Stiffness more than 1 hour characteristic for rheumatoid.
And for ankylosing,
Less than 30 minutes. All seronegative.
But I think, Dr. Azhar, rheumatoid in the joint, not in the back.
Yeah, yeah, in the joint. But if he asked about stiffness, I mean stiffness, right? You ask about stiffness, yes. Not the back pain, the stiffness.
Yes, okay.
Okay,
and
stand
in the
up.
SLE, patient will have
SLE.
stiffness.
It's SLE if mixed connective tissue disease. It will be stiffness. By the way, it's a Jacquard arthropathy.
Yeah, Jacquard arthropathy. It will be
Yeah.
stiffness. There will be stiffness in Jacquard arthropathy.
No, I
Yes,
don't think so.
inflammatory.
But it's not like rheumatoid. I think rheumatoid only stiffness, significant stiffness.
In lupus, less than 30 minutes.
Maybe less, but the rheumatoid only having the longest duration for stiffness. Okay, stand up. Yes, I asked him for this. Dr. Fatma, look at the posture. Yes, back and the movement. Nail, of course. Nail biting, pulse. Yes, collapsing. Aortic regurg, scalp psoriasis. Examine anterior vitis by torch. Yes, Dr. Hadil, thank you. Chest examination from the front. There is no upper loop in the back. Dr. Muhammad Mustafa said, we raised this issue before. Dr. Ahmed Ali, thank you. So we will not examine the epics from the back? This is a question for me. I want to examine, yes, the apical area
Yes.
from the front. Yeah,
Just to explain, Dr. Basim, thank
yes.
you for the case. Actually, for all the cases of fibrosis, it is better to be examined in the back because it is in the basis. But in the conditions that the fibrosis is apical only, it is better to examine, or maybe the best is to examine from the front. This is the only exception. If you have apical fibrosis in this disease or in other disease like scoliosis or any other thing, you just examine from the front, the epices from the front, not from the back. Back, if you suspect that basal fibrosis.
Yes, okay. Thank you, Dr. Muhammad. Thank you.
Yeah, thank you, sir.
I will try to remember it again because Dr. Muhammad said, or Dr. Ahmed Ali said, we mentioned it before. Okay. Let's go to the next. Please post the case, Dr. Mahmoud. Whole body examination, yes. Inflammatory association to ankylosing S2 Oh, you post the case already. 52 years old, has convulsion. This morning only. Please take history and address any concern. IgA nephropathy, non-steroidal amyloidosis. ATN, of course, as use of non-steroidal. Remember the explanation of ankylosing, it's not autoimmune, it's inflammatory. So it's soreness inside your backbone or between the backbone areas or joints. Atlantoaxial subluxation, Dr. Nada said, I think here there is no subluxation in the rheumatoid.
Rheumatoid.
Yes. L5 radiculopathy, superficial branch. Yes, back pain. Okay.
Sorry, Dr. Basim, about the job and the driving, what I will
Yes,
do?
it was raised before. So, own car, and he doesn't have any of them. You have to ask the patient specifically. Do you have any impact on your driving by this? How?
Mm.
By either eye problem or the limitation of his neck. They said there is a solution. They can provide special mirrors. But you have to ask this question: is it affected or no? Because it will harm you. This is for the own car. He can sit in his seat and he can see or whatever. This is in his own car. Imagine bus. Patient is bus driver. A lot of persons with him. Do you think it's safe to give him the risk to drive while he's telling you, doctor, I cannot see the sides? So the best thing is to hold and let him update it by Divla. He can see the sides, he cannot see the sides. Be safe and advise him immediately. Refer him to Divla and they will see if he can drive again or no. Okay, but I think no. But for the own car, they found a solution, which is a lot of mirrors or arranging more mirrors so he can see without moving his necks extremely. Okay,
Yes, about the job.
the job.
I will re-regulate him or
No, hold the driving and tell him we'll update you after
yes,
assessment. And also you have to inform DevLab because he might, I think he's not able to do again the driving. Okay, why? Because it's risky for him and others.
yes.
But in his cars, that's it. He's the only one driving. But for the heavy vehicle, it's more risky. Okay.
Okay, Dr. Basim.
Okay, Mr. Again, sorry, I didn't.
Mr. Sami has convulsion this morning.
Okay, Sammy, let's start.
Okay.
Hello,
Hello?
doctor, in the clinic today.
Yes, doctor. How are you?
I'm fine. I will take history from you and I will examine you after that. Can I confirm your age, please?
Yes, 52 years old.
Okay. Tell me, doctor, tell me, Sammy, sorry, about your complaint.
Yes, doctor. This morning I have a fits. It is the first time, and I think it lasts for 20 minutes. I don't know why, doctor, really.
I'm so sorry to hear about that. It was the first
Thank
time
you.
ever in your life.
Yes, doctor, the first time.
Okay. Can you remember what happened exactly before it? What you were doing?
Yes, doctor, I was taking breakfast with my wife, and nothing. Just I lost my consciousness, and then my wife woke me and tell me I have fits for 20 minutes.
Yes. Again, sorry to hear about that. Mr. Sami, you lost your awareness during that time, right?
Yes, doctor.
It was witnessed by your wife, right?
Yes, my wife
Did
is
she did she
yes.
did she tell you that you bite your tongue?
Yes, doctor, I bit my tongue.
And did you lose the control over your water work? And sorry for this back passage.
Yes, doctor, it was very anxious for me. Yes.
Okay.
Yeah, right.
After that, you regain your awareness totally.
Yes, doctor, I return
Any
normal.
any headache?
No, doctor. Now
Okay.
or before?
During yes.
During no, doctor.
And after you regain the consciousness, do
No
you feel
headache,
headache? No headache.
No, doctor. No, doctor.
Okay. Anyone checked your blood sugar?
Yes, doctor, I'm diabetic, but my blood sugar was controlled. It was normal.
So they checked it. Okay. Did
Yes,
you
doctor.
feel sweaty during that time?
No, doctor, I don't think so.
Any heart racing?
No, doctor, never.
Any chest pain?
No,
Okay. Any specific position before happen or before the attack happened?
no, doctor, I just sit in the chair taking a breakfast. No other thing.
Okay. And no head
No,
trauma
yes.
or any trauma to your body recently or before?
No, doctor. No,
Okay, good. Okay, after that,
no,
you
doctor.
told me you regained the awareness and you feel well now. It didn't happen again. I mean the shakiness.
Yes,
Did
doctor,
it?
it didn't happen again. No, doctor,
Okay,
no.
okay. Did you know that all your limbs moved, like your hands and your legs, or you don't know?
Yes, doctor, my wife told me that all my limbs was shaking.
Okay, and your eyes was rolling up.
Mm, I didn't think, doctor. No.
Okay, it's okay. Back to your diabetes. You told me you have diabetes for how long you have diabetes,
Yes, doctor, I think from 10 years.
and what medication you are receiving,
I taking insulin, doctor.
and you are compliant.
Yes, doctor, full compliance.
Did you increase any dose recently?
No, no, doctor.
Did you add any medication?
No, doctor.
Okay. You have any infection recently, like sore throat or infection in your...
No, no, doctor.
Okay. Uh, you have any surgery before?
Yes, doctor, I think I have, yes, I have surgery since 1 year for losing weight.
Okay. So you did the sleeve, right? Or what
I
type
don't
of
know.
surgery? You cannot remember?
I don't know, doctor.
Okay, good. And did you take any medication after that?
Yes, doctor, they give me some supplement, but now I didn't take anything.
Can I know this supplement?
Yes, I think iron and vitamin B12 and the calcium.
Okay. And when you stop them?
I think since 3 months.
3 months. Okay.
Yes.
And any instruction to stop it, or you stop by yourself?
Really, doctor, I stopped by myself because I have severe heartburn from this medication, so I stopped it.
Okay. I appreciate your concern about that, but please, we will update you about that. For meanwhile, it might be related, so we can involve in our meeting the group of doctors. One of them will be the doctor who did the surgery for you. You might resume this medication, okay?
Okay, doctor, but I stopped it since 3 months, so
Yeah, it
I'm
might
okay.
be, but we'll do our best to know what the cause
Okay,
behind
doctor.
this. Okay.
Thank you,
Any
doctor.
any allergy for any medication?
No, doctor.
Show me your medication list. Insulin
I take
only.
only I took in only insulin and only that. Yes.
Okay. You have headache, so I will ask some questions.
No, doctor. No, no,
Any blurring of vision?
no,
Any hearing problem?
no,
Any unsteadiness
no, doctor.
or balance? Any weakness?
Weakness? No,
Any pins and needle sensation?
no.
Any mouth sores?
Muscles? No,
Any short of breath?
no.
Any chest pain?
Not chest pain, doctor, but I have severe pain, body ache in all my body.
Since when it started?
I think, doctor, since 1 month.
Okay, and did you seek medical advice?
No, doctor, I just take paracetamol and be
Does
okay.
it help?
Yes,
Okay, and this pain, if I give you scale from 0, no pain, and 10 is the maximum, how you can scale this pain?
I think two, doctor.
Okay, and any, you feel any muscle cramps?
Yes, doctor, you are right. Yes.
Where exactly and when?
Yes, my leg. When I walking to supermarket, I feel yes muscle cramp. You are right.
Okay, and this comes improve with the rest?
Yes, improved with rest, doctor. Yes.
Okay.
After sometimes it improved.
Okay. Back to your other questions related to, it might be irrelevant, but it might help us. You have any tummy pain?
No,
Any change of your bowel habit?
no, doctor. No,
Okay, any change of your water work?
no, doctor.
Any skin rash?
No,
Any joint pain?
no,
You have any high body temperature?
no,
Anyone told you you are paler than before?
no, doctor.
Any yellow change in your eyes?
Any what? Sorry.
Yellow
No,
change.
no, 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 doctor. No.
Okay, any change of your appetite or your weight?
Yes, doctor. I lose weight.
How many for how long?
I lost I think 20 kilo for 20 kilo for last 4 months.
Yeah, so it's related to the surgery, right?
Yes, it is a tendon, doctor. Yes, you are
Okay,
right.
intended. Okay. Any lumps or bumps?
No,
Okay. Any family history of same condition?
no, doctor. No,
Any travel recently?
no.
Sorry for this question. Do you have any difficulty in intimacy?
No, doctor. No.
Okay, for the diabetes, can I ask you some question? Do you have any uncontrolled or hypoglycemia or low blood sugar level
No,
before?
doctor. Never, doctor.
Never. And last reading for the 3 months hemoglobin related to
Yes,
the
doctor.
blood sugar, how
Before,
much?
yes, before the my surgery, it was elevated.
And now?
That's why I do this surgery, and now it is controlled. It's around 6.57, like that.
Okay, good to know. May I examine you and might ask you some question while examining? So I will start by the general look and the surrounding. Any surrounding? Any
No, 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 sir, no.
the general look, how the patient look? He is obese or
No. Normal
average
patient.
weight? Okay,
Average
but
weight, yes.
body mass index, I will ask for body mass index.
Yes, patient weight now 80.
Okay. Now I will examine from the hand. Any pallor in the hand?
No,
Leukonychia, koilonychia?
no.
Nothing. Then I will palpate the pulse.
Pulse normal,
Normal. And the
around
vital?
70.
All
Blood
vital
pressure,
chart.
yes, blood pressure normal, temperature normal, saturation normal.
Okay. Any clubbing in the hand?
No,
Okay. I will do. You feel if you feel pain, let me know. Okay. I will check for paroxysmal myopathy, proximal myopathy. Any proximal myopathy?
no, doctor, but I feel general body ache. So
Okay.
no, I
Okay.
can't.
Now, okay, no
Yes,
problem. Have a rest. I will examine now the
thanks.
face. Any pallor or jaundice in the eye?
No,
Nothing.
nothing.
Uh, I will offer for shove stick and trousseau. Trousseau in the face because I'm in the face. Sorry, shove stick in the face because I'm in the face.
Okay, how do you do?
I will tap in front of the ear and I will observe for any contraction in the mouth.
Okay, doctor, no
And
need.
no need.
Yes,
Okay, I will offer trousseau by blood pressure measurement above the
okay,
systolic.
okay, no need,
Then
doctor.
I observe for any carbopedal spasm. Nothing.
Nothing, no need. Yes,
No need. Okay. Now I will. Any you feel any some tingling around your mouth, Mr. Sami?
yes, doctor, you are right. Yes, yes.
You feel and what happened exactly?
I think, doctor, since 2 months, I feel some tingling around my mouth.
And
Yes.
it happened any particular time to happen?
No, doctor, no specific time. It comes and go.
Okay. Did you take anything for it?
No, no, doctor,
Nothing.
nothing.
Now I will examine the heart for any murmur. Detect the apex first, then I will examine for any murmur,
No need.
especially
Mm,
aortic stenosis
No,
murmur.
nothing.
No. Okay. Raise GVP.
No, no, nothing.
Okay. Do you smoke, Mr. Sami?
No, doctor, never.
Do you drink alcohol?
No, doctor, never.
Okay. What's your job?
Manager.
And how
Company.
that impacting on your job?
Not impacting, doctor. Just today morning I have these fits, so I didn't go to my work just today.
Okay, good. I will try to help you in this regard. If you want, we can help you with our social work. Okay.
Thank you, doctor. Thank you very
Okay.
much.
Back to the examination, I will examine the abdomen, any by superficial palpation, any problem, any tenderness,
Again,
sorry.
again, sorry, doctor. Again, sorry, doctor.
Superficial palpation in the abdomen, any tenderness.
No need, no need.
No need, and tell me if the 2 minutes left, please, okay?
Okay.
Now I will examine for the leg swelling or leg edema, any leg edema,
No,
nothing. I will
nothing.
do reflexes in the legs. I will do Babinski and ankle reflex.
Yes, normal. Normal.
Normal reflex.
Yes.
Okay. Any family history of cancer, Mr. Sami?
2 minutes left. Yes, doctor. My father died due to brain cancer. 2 minutes
Brain
left.
cancer. Okay, I'm
Yes.
so sorry about your loss.
Thank you, doctor.
What are your concerns?
Yes, doctor. What I have? Is it cancer
Yeah,
like my dad?
I appreciate your concern and your worry, Mr. Sami. Actually, it's not or less likely to think about cancer. What we are thinking about, it might be some deficiency in some of the salts in the body. It might be either calcium, or it's called the calcium or phosphorus. It might be in the supplements you were taking, but since you stopped them, it might be now deficient, and it had the same manifestation what you had. You have any other
Doctor.
concern?
Yes, doctor. Is it serious?
I appreciate your concern, Mr. Sami. Yes, it's serious if you didn't take the medication back, and if it is low, seriously, it might have effect even on your heart. And I'm so sorry to say this, but you have to take care of that. It might even stop your heart, and it's threatening your life. For which I advise you again. We will start some of the correction after confirm the diagnosis. But for the long time or long life supplements, you have to take according to the medical advice. You have
Okay,
any
doctor.
other concern?
Yes, do you admit me, doctor? Do I am going to be admitted?
Yes, I appreciate your worry again. You have to be in the hospital for meanwhile. We will run some blood tests to confirm the diagnosis and rule out also if you have other problems that cause seizure or the fits or the shakiness, to be sure that it's not serious. However, the low salt, which is calcium, called calcium, one of the serious causes of seizure. We will admit you to commit to correct this deficiency, and we will let you know about the further plan. How
Okay,
does
doctor.
that sound
Thank
for you?
you. Okay, doctor. Thank you. Time finish.
Okay.
Okay, Dr. Basim, what's your diagnosis?
Yeah, symptomatic hypocalcemia, severe hypocalcemia, complicated post bariatric surgery. It's related to, I mean, the deficiency or insufficiency of calcium because he already stopped the medication as supplements. He had history of bariatric surgery and he stopped the medication supplements. I mean, he had a history of perioral sensation or tingling, sorry, and also he had cramps, a history of cramps when he stopped the medication or appeared after stopping this medication. So on top of my differential electrolyte disturbance, on the top of them, hypocalcemia or symptomatic severe hypocalcemia.
Okay, doctor, do you have any other deficient diagnosis?
Yes, I can think about hypophosphatemia as well and other electrolyte disturbance, hypokalemia as well. And also I can think apart from electrolyte disturbance, I can think about hypoglycemia. However, he denied any hypoglycemia attacks before or even during the the seizure, the reading was okay.
Doctor, what will you do to this patient? What's the investigation?
Yes. First of all, I will admit this patient and I will do blood basic investigation like CBC to rule out any anemia, inflammatory markers, and specific investigation will be full electrolyte and bone profile, sodium, potassium, and renal function tests as well, plus calcium, phosphorus, and parathyroid hormone, vitamin D level. Apart from this, I can do also liver function test, ammonia. However, he doesn't have any liver affection or hepatic affection before. Yes, then I can also do EEG, CT brain to rule out any organic cause, and EEG to confirm there is no epilepsy now.
Okay, what else, doctor?
What else?
Yes.
Vitamin deficiencies. I can do also vitamin screening for vitamin B12, all vitamin screening, and iron workup. Then I will do
Okay.
albumin also for corrected calcium level.
Yes. Good, very good. Okay, what else?
Yes.
You tell the patient.
I tell him yes, all electrolytes, and
what?
yeah, I forget driving. Oh my god.
Yes, you forget driving. Yes, I know.
Okay.
Okay, no. You tell the patient you will stop your heart if you not admit
Yes,
him.
ECG and echo. Yes,
For
ECG and echo.
arrhythmia. Yes.
Yeah.
Okay, what is your management plan treatment with this patient? How would you like to
Yes.
treat the patient?
A multidisciplinary team approach, nephrologist, cardiologist, and bariatric surgery, specialized nurse, social worker, occupational worker.
Why nephrology, Dr. Bess? Why nephrology?
Nephrology for severe electrolyte disturbance, we usually call them.
Okay.
Okay. Because it will not be calcium only. Sometimes it will be also phosphorus, potassium. Anyway, correction by IV calcium is mandatory with IV calcium gluconate. And for the long term, patient might start on oral supplement calcium chloride. If the heart is affected or there is prolongation of QT, I can start on calcium chloride or calcium gluconate. For the long
Yes.
term, patient will receive calcium carbonate as
Yes.
oral supplements.
Yes.
Apart from this, correction of other electrolyte if there is hypophosphatemia, hypokalemia, and also check for the sodium level.
Okay, Dr. Bassem. Okay.
Differential.
I am finished now. No,
Differential.
differential diagnosis?
Yes.
Oh, yes. Okay. What is the differential diagnosis?
Yeah, I said
No,
hypocalcemia, right? Hypocalcemia,
yes,
hypoglycemia,
yes, hypocalcemia, hypomagnesemia. Okay,
hypoglycemia.
this case is a new trend now in basis. Hypocalcemia. This is a new trend now. Hypocalcemia come as post-thyroidectomy, post-bariatric surgery, and celiac, and also tumor lysis syndrome. And also hypocalcemia may also in rhabdomyolysis. So these 5 causes in basis appeared recently in exam. These 5 cases appears as
Again, name them.
Yes,
post-thyroidectomy and
2 operation, post-thyroidectomy. It appeared patient convulsion and post-thyroidectomy. This scar for post-thyroidectomy.
Yes, of course, yes.
Post-thyroidectomy, post-bariatric surgery, and celiac, and tumor lysis syndrome, and also
rhabdomyolysis.
Yep. These 5 cases appeared recently in basis exams in all centers. Hypocalcemia. It is a new trend now in basis exam. Hypocalcemia. So hypocalcemia symptoms will be circumoral numbness, body ache, convulsion, tetany, and muscle cramp. 5 symptoms for hypocalcemia. Examination like Dr. Bassem did, Juvestock and Dr. Wajé, and also proximal myopathy. And also, Dr. Bassem, we have to do neuro examination. We have to do the tone and the power and,
yes,
and
right.
the plantar
yes.
and the sensation. Just one from each one.
Yes, yes.
one power
Yes.
and one sensation.
You're
We have
right.
to do
Pronator drift also I have to do.
yes, it is a convulsion, so it is neuro. Also, I think we have to fundus to do fundus examination. The examiner will refuse, but we have to provide fundus examination. Investigation like Dr. Bassem did, CBC and alkaline phosphatase, calcium, parathyroid hormone, vitamin D, phosphorus, plus albumin, because it will be calcium decreased and albumin may be decreased, so we have to do correct calcium
Correction of the LC.
correction of the calcium. And also the most important is ECG to do arrhythmia. But I think Dr. Bassem, about the admission, the examiner يعني get nervous if you tell him any patient admission. So if the patient not need admission, not provide admission. That is, the expression of the candidate. Any candidate told that I will admit the patient, the examiner will be nervous. So he didn't any patient to admit, even in the acute, like pancreatitis, acute abdomen. So I think this case not to be admitted. Patient stable. We have to do investigation as a routine and give him supplement and go back and the patient return back to do another investigation. If still decreased, so we will replace him by IV, but first by supplement, oral supplement. So I think in this case not to be admitted.
For the welfare, والله, I think for the
Yes,
severe
but
hypocalcemia.
Dr.
Yes, I
Bassem,
know you are delivering what happened exactly, but
all the candidate told me, even I told the examiner I will admit the patient, the examiner nervous. Why admit this patient? Why is this patient is stable? So the examiner the
not
last,
stable. Patient had a seizure and he's stable.
but today morning the patient now stable.
Okay.
So we have to release the supplement only.
Okay.
So that is the new trend now in basis of hypocalcemia. It is a new trend.
Okay, thank you, Dr. Mahmoud.
Thanks,
Nice.
Dr. Bassem.
Very
Sorry, admit him to give the gluconate.
Sorry?
You need to admit him to give the calcium gluconate.
Wallahi, this is my also thinking, but
This patient for admission, he has fits and severe hypocalcemia.
Yes, I know that, but I told
all,
just I told
The
the,
calcium
all
gluconate.
the meeting will kill the consultant.
yes,
No, I will totally disagree with the consultant,
Yeah,
even
me
if he's a
too. Me too.
consultant.
Yes,
How
yes,
I will
but
correct
yeah,
calcium? Even I will look for the number. Okay, I can say after detecting the
Symptomatic.
level of calcium,
Yes,
but
yes.
it's
I agree.
symptomatic, and it takes time. By the way, Dr. Mahmoud, it's not.
yes, I am with you, Dr. Bassem. If this
Yes,
patient come to my hospital, I will admit him in ICU, not in the ward, in ICU.
Yes.
But I
It's
just
severe
told you,
hypocalcemia, yes.
yes, I will admit him in ICU really.
symptomatic.
But I just told that the expression of the examiner, if you told him admission, he will get nervous. Really, a lot of.
He will have prolonged QT interval. How you won't admit him if he have prolonged hypocalcemia and have prolonged QT interval?
Okay, Dr. Salah, I
You
told
should
you
admit him.
if this patient come to me, I will admit in ICU.
No, this
Really.
examiner is not understanding anything.
Yes, I am with you, but the examiner, the only thing I
Examiner,
think,
they do not know anything. Now they forget each and everything, I think.
Yes.
yes, Dr. Azhar,
Because
but
they are not reading. They are not
I
reading
just-
anything.
I just told you that the examiner get
Yes,
nervous
yes.
if you admit. Really, I am sure. You have two cases in the basis, long consultation. One case is acute, okay, that's for admission. And the second case will be chronic.
Yes,
Like-
I agree. Yes.
So if the patient chronic, take care not to admit the patient. If the patient acute, also take care. But I have a lot of friends failed, told me, yes, not this cause, but they told me when I practice with them, I told the admission. They told me that the examiner, when listen admission, you should be sure that why admit the patient. I think consultant in UK يعني doesn't like admission of a lot of patient. So if the patient not have the criteria of admission, not provide the admission. You will tell that we will do some tests, some scans, just like that.
Okay,
just-
if the opposite, we didn't admit, they will minus in the welfare. I let the patient go home.
Yes,
and
sure, Dr. Basim. If the patient is acute abdomen patient, porphyria, even porphyria, you will admit the patient. Porphyria, admission the patient. Patient has hypercalcemia, must admission the patient. But think a lot before tell the examiner, I will admit the patient because he will get nervous from this
Okay.
word. Really, Dr. Basim, I just told to you. But
No,
this case,
it's okay. We can refer to the specialized team, and they will decide for admission or no. I will
know-
answer like this.
Or like
you know,
this,
Dr.
I want to do for you some blood test to check the level of the calcium. If it is low, we
Yes,
need to correct it.
yes,
Because
that is
afraid from arrhythmia or even seizures, not seizure alone, it may be get patient arrhythmia that may be leading to the death for this
Yes.
patient. So
Yeah,
yes,
if
good
there is
option.
a
I am
There
warning
is
the patient,
calcium
then I
very
will not
slim,
admit him.
and
yes,
they
there
decided
is
to admit you or not, can I said like this?
yes, there is also another option.
Yes, I can do
We
it in
will
a diplomatic way, yes, as
yes,
Dr.
there is also
Muhammad said.
another option, option.
Okay, say
We
yes.
can tell we keep him in ambulatory. That is the like triage in our hospital.
Emergency, yes, in the emergency
Yes,
unit.
do some investigation like ECG and
يسموها
calcium.
short stay unit لأنه الأمبيولاتوري كير مقصود فيه units متحركة خارج المستشفى.
In English, Dr. Hind.
ambulatory care إنك تعطي IV برا المستشفى، تعطي كير ميديكال كير برا المستشفى، فهي بيسموها اللي أنت
Yes,
قصدك عليها
yes,
short
Dr. Hind.
stay short stay unit.
We
Dr.
will
أو
not
Hind,
give
مثل ما أنت قصدك إنه مثلا
in
you
English,
to
Dr.
correct
Hind.
الكالسيوم IV بالأمبيولاتوري كير، يعني ما يضطر إنه يدخل على المستشفى، بس أنت
Dr.
بدك مونيتورينج، أنت بدك
Dr.
تعطي IV كالسيوم، هذا ما
Dr.
No,
Hind,
بدك
in
Dr.
تقول
English.
للمريض امشي.
In
No,
English,
Dr.
for example.
Dr. Hind, no, I asked, I told the ambulatory to take some investigation
هذا
like
اسمه
calcium
شورت
level.
ستي يونت، هذا اسمه
Short
شورت
stay unit.
ستي
Okay,
يونت.
Yes.
okay, short stay unit. Okay, خلاص.
تمام. الامبيولاتوري كير هدول عباره عن مثل فاسيلتيز متحركه بينشروها واماكن صغيره، يعني حتى بتكون بسيارات مخصصه ومهيئه بسموها
Caravan.
ambulatory care. But
Caravan.
I think those for IV antibiotic for someone who's more stable، يعني he need to take some IV medication
Yeah,
and go back.
not for, yes, I
Short
agree.
stay unit is something in the middle. It's not
Okay,
admission, it's not discharge.
okay,
Or something يعني could be used.
okay. Thank
Dr.
you, Dr.
Mahmood,
Hind.
Yes, Dr.
Dr.
Azhar, yes.
Mahmood,
Yes.
what is the difference between calcium gluconate and calcium chloride? In which condition you will give calcium chloride? In which condition you will give calcium gluconate?
I don't know really.
It's
I
simply
If
in hypocalcemia symptomatic, asymptomatic. يعني if you think, you will get it.
But what I know is that if the patient is having arrhythmia with hypocalcemia
calcium
or life
gluconate.
threatening,
IV.
we will give calcium chloride,
Yes, IV, yeah.
IV. And but if the patient is not in arrhythmia, we can give
Yes,
calcium
okay, calcium
gluconate.
gluconate.
So this
Okay,
is the
difference chloride and gluconate. Okay, I
Yes,
thought
yes,
the
yes, yes.
carbonate and gluconate. Okay, yes, you're right.
Yes.
Yes. So with heart affection or arrhythmia, yes, chloride is much concentrated and
Chloride.
more effective. Yes.
Yes, if without arrhythmia, then we will
Yeah.
give calcium gluconate.
And in asymptomatic patient, we can give the oral supplements, calcium
Yes,
gluconate.
yes, in asymptomatic, we can give oral.
Yes. Yes. Thank you, Dr. Mahmoud. Nice case.
Very nice case.
Yeah.
I just give this case to Dr. Basim because be aware about hypocalcemia.
Yeah. Thank you. It's nice.
And then
Also.
if the examiner can ask you, what are the causes of convulsions? Then how?
Yes,
how will you-
hypocalcemia. Patient stop calcium.
No. Generally, what?
Yes, generally it will be metabolic, neuro, cardiac causes.
You
In
will
these
remember
patients?
vitamins. V, vascular causes, stroke. Then I, infections, meningitis, abscess. T, trauma,
Trauma.
tumor. A, autoimmune like SLE. Then M, minerals, any mineral, calcium, sodium, glucose. Then again I, idiopathic, and neoplastic, and S means special condition like tuberous sclerosis and Sturge-Weber syndrome. So vitamins, it's written in the books. In the neurology books, it's written. This mnemonic.
Okay, Dr. Azhar. You can type them also again in the group.
Yeah,
Inshallah.
okay.
Tomorrow
Yeah.
morning, inshallah, I will type.
No
tomorrow
problem. No worry. No worry. Take your time. Thank you, Dr. Azhar.
morning.
Dr. Najla asked, what's the cause of hypocalcemia? It's related to the supplements. Hypocalcemia, low intake. You know, post bariatric surgery, they remove part of the bowel or the stomach, and it's sometimes either for the absorption or protein or conjugation with some protein to be absorbed. That's why they are compensating with oral calcium.
Yes, Dr. Bassem, bariatric surgery have 3 complications in basis.
Dumping
them
syndrome also
is-
one of the important, yes.
Yes, dumping for hypocalcemia
Hypoglycemia.
and hypocalcemia. Patient was taking hypocalcemia and stopped this medication by herself because
Mhm.
she felt some heart pain, so stopped this medication. And the third one is confusion. Patient may come post-bariatric confusion due to thiamine deficiency, which is vernix
مو بس confusion, diplopia واتاكسيا.
اوكي.
تمام. فيعني
دكتور
ما شاء
هند.
الله يسعدك كيف يعني مبين عليك جايب كل سيناريوهات البيرياتريك. الثايمين deficiency very tricky.
Yes.
very tricky scenario. could be confusion مثل ما قال, could be يعني patient alcoholic, ويرنكس, فبدخلك بالويرنكس والالكحوليك والبيرياتريك سيرجري, حتى احيانا بيكون في repeated vomiting, فكلياتهم بياخدوك على طريق الثيامين. بيكون عنده diplopia واتاكسيا وconfusion, sometimes even memory issues. تمام. you have to check what before replacing الثيامين, أو also you have to replace with the thiamine الجلوكوز. usually حتى بالبرياتريك سيرجري بيكون في عندهم hypoglycemia و issue in regulating the glycemic load. you should take care of the thiamine, of glucose, هالأشياء هي كلياتها مع الإلكترولايت, و you correct الثيامين, يعني you should correct all these things, يعني مو بس الثيامين, الجلوكوز, الثيامين والإلكترولايت, بالذات لما يكون برياتريك.
Why the glucose before thiamine, Dr. Hind?
لأنه بالعكس هو الثيامين before the glucose, لأنه لما بتعطي جلوكوز فتو metabolize الجلوكوز you need thiamine, فاللي حيصير إنك you will consume the remaining store تبع الثيامين in the body.
Yes.
Exacerbate الكيس. فالثيامين is a cofactor in most of the metabolic pathways of glucose. فgive the cofactor, then give the glucose. تمام.
Yeah, so I will start correcting the glucose, then
you will
thiamine.
start correcting the thiamine, then the glucose.
Yep.
لأنه لا تنسى كمان الهايبوغلايسيميا is a good differential, لأنه
Yes.
confusion, neurological symptoms, okay, و patient pediatric. just make sure إنك to correct الثيامين before the glucose, وإنك to correct any electrolyte disturbance, لأنه these three are the best differential diagnosis in this patient. بس طبعا التوب is thiamine. Whenever you see diplopia, cerebellar in the form of nystagmus أو ataxia plus confusion, you will keep الثيامين top, بعدين hypoglycemia, electrolyte. Okay, if you have a comorbidity it can contribute. تمام. At least الثيامين ما حيوصل للسيجر. When you find seizure you will prioritize الhypocalcemia. تمام. فالسيجر والمسل كرامس they prefer الهايبوكالسيميا, وأحيانا الهايبوكالسيميا صار يجي بالفتيج, فتيج ومسل كرامس with or without seizure. تمام. فتake care of this. وأحيانا arrhythmia. تمام. those are different من الثيامين, you will put hypocalcemia on the top. لو في neurological symptom thiamine, والأشياء البقيانة بقى. تمام.
Okay, thank you. Any question or any comment?
بس كمل دكتور محمود لو عندك أي سيناريوهات تانية على البرياتريك. في وحدة إجت جولستون. It's very common. مع إنه بالعادة هن يعني take care إنه before you say gallstone إنه إذا عندك abdominal pain ask him if they remove the gallbladder. لأنه مرة once it was a trick, there was an abdominal pain, بس the patient during the pediatric surgery bypass usually they remove the gallbladder. So it is good to ask whether they remove the gallbladder before you put gallbladder stone as a differential. بس أحيانا بالسليف إذا it was not a bypass. عشان هيك بيقول لك the type of the pediatric surgery is very important. if it is a sleeve, it's not necessary that they remove the gallbladder. But always ask before you give any differential. لكن gallstone is a case. Thiamine deficiency, hypocalcemia, vitamin B12 deficiency. He
And
will
what mechanism of
again-
gallstone?
Mm?
How it happened? Because of cholestasis?
What الفيتامين B12
The gallstone
الجولستون لأنه أنت
medication
usually
side effect?
when you لا مو side effect. Usually when you change I think it will be a cholesterol gallstone. I forget
Mechanism?
الميكانيزم exactly. بس السي اس كي كان اسمه السي كي كان ينفرز من الابدومن، مكان بالابدومن، وهو اللي بيساعد على انه الجول بلادر تنقبض. تمام.
السي سي كي.
سي كي كان اسمه. المهم شغله بالفسيولوجي والديسترب. فحيصير في بروبلم بقلب السكريشن، حتصير more concentrated او less الفانكشن تبعها السكريتوري فانكشن is less. I'm not sure بس بتذكر هيك شيء. تمام. فبس انه الجول ستون is common بالبرياتريك after the bariatric surgery. الثيامين، وقلنا مين كمان فيتامين بي 12 deficiency. تمام. لانه كمان الانترنسيك فاكتور بينفرز it is secreted from one part of the abdomen. تمام. since one part of the stomach. if you cut this part ما في intrinsic factor vitamin B12 deficiency. وكمان بيعمل neurological symptom. تمام. take care of those. all of them are scenarios. وكمان الجاستروباثي. تمام. البيشنت بتصير في عنده symptoms of delay emptying of the stomach. تمام. لأنه when you cut the tummy after the surgery tummy will be lazy. تمام. sometimes if recently done you will find some gastroparesis symptom. كلياتهم هدول risk factors after the bariatric surgery. They came as a scenarios.
Okay, for the anemia and iron also absorption.
كمان الايرون absorption as a cause of anemia مع الفيتامين. بس طبعا لو عطاك MCV it will be a big help. لأنه الايرون it need acidity environment to be absorbed.
Yes.
تمام. no acidity no good absorption of iron فبيعمل لك anemia. عشان هيك asking about the supplements, whether he's compliant to the supplement, when the bariatric surgery was done, what was the type of the bariatric surgery. تمام. asking about the symptoms of all those elements is very important. vitamin B12 لازم نحفظ السيمبتوم تبعها، الثيامين، الهايبوكالسيميا، الايرون deficiency. تمام. واحيانا they are يعني بيقول لك قبل يعني احيانا الانيميا لازم نفرق بالايرون بين الايرون deficiency with anemia without. Sometimes you have a restless leg syndrome you have symptoms of iron deficiency anemia لكن الهيموغلوبين is well corrected. تمام. بالذات إذا هو he took a blood transfusion. فهالأشياء هي صاروا كتير ركزوا عليها إنه it's not necessary إنك تشوف الهيموغلوبين low. Sometimes he can give you normal you will find the patient have hair loss have restless leg syndrome. كنت حافظتهم من أول السيمتومز تبع الايرون deficiency من دون الأنيميا. بس هلا ماني متذكرة غير هدول الاثنين. But these scenarios are really good to remember about iron deficiency. ما بعرف اللي خطرت ببالي هلا وقت انت جبت سيرة الايرون. Pediatric surgery is very important. Don't forget to open the tummy. Despite your case will be surgery with neuro, you will be far away from the abdomen. You should open the tummy. You should point out the scar.
Yes. Yeah, supposed to tell that I should explore the scars. Okay, thank you, Dr. Hind. And for the driving, Dr. Yeah, Dr. Yunus. Yes, Dr. Azhar, go ahead.
Yes, examiner, may I ask you, why after bariatric surgery there's a deficiency of iron and calcium? What is the reason?
Acidity. Right? Lack of acidity. For divalent ions, we need acidity.
He wants to ask that iron and calcium is absorbed in the duodenum. Duodenum is responsible for the absorption of iron and calcium. If they have removed duodenum, that's why there is a deficiency of iron and calcium.
But first, in the acidity, I think the charge
transfer,
will be the charge will be changed. in the
From,
abdomen with the
yeah.
acidity. Then
Yes.
after changing the charge, the
Absorption.
charge become different, I think. I forget exactly. Then they are available for absorption in the duodenum. So
Yeah.
even if
From
we
ferric to
remove the
ferrous.
stomach,
Yes. Yes, you're
you
right.
will disturb the absorption. Because I still remember the acidity have a role.
Yes, from ferric to ferrous, from +3 to +2.
بس
Or the opposite.
الكالسيوم I'm not sure if the same role apply for the calcium, but for the iron I'm sure. إنه you
No,
need
calcium is
acidity of
absorbed in the
stomach.
duodenum. Calcium is only absorbed in the duodenum. So if duodenum is removed, there's a deficiency of calcium.
So
Yes.
it is only the bypass surgery which can lead to hypocalcemia, right? Okay.
Yes, yes.
That's why I think there is different complication for the sleeve versus bypass. It's not the same complication because even the structure which usually removed are different. And in the sleeve only you will touch the stomach, but in the bypass, the duodenum will be also resected. So I think we have to revise since they are making like that, since it's a hot topic now in the exams.
Yes, thank you. Nice discussion as usual. Nice case, Dr. Mahmoud, as usual.
Thank you, Dr. Basim. I have another case from UK, but it is very interesting case. Really, from UK, come in UK only.
So you have one more time experience with us, right? Practice.
The day after tomorrow, it is a very interesting case, but must be Dr. Hinde here because Dr. Hinde, she will know this case.
Okay.
خلاص لكان طب اسمعني
دكتور.
إذا من هون لبكرة ما بعرف شو صار معكم، ما في حدا أخذ الكيس أنا موجودة.
No, the day after tomorrow.
inshallah.
It will be interesting case. Come in UK. Only in UK.
Okay.
Okay.
غير الأوستيوجينيسيس imperfecta والسودوزانثوما
No. It is, no one will know this case.
Okay.
Except Dr. Hind. I am sure Dr. Hind
keep
will know this
keep
case.
it surprise till the
Yes.
day after tomorrow, inshallah.
till after tomorrow inshallah. I will try really to attend بإذن الله. Tomorrow is communication, that's why you will give it after tomorrow. تمام.
Yes.
Dr.
Okay.
Mahmood,
Yes,
after
Dr.
tomorrow, how many cases you have, you will bring, and you will do the cases. And you
I have really a lot of cases, Dr. Azhar. but
your
this
cases
case
are very good. Your cases
No.
are very, very good.
Yes, no, the case day after tomorrow will be interesting one, really interesting. It is a small case, but no one will know this case. I'm sure.
You can
I will
do it
ask
now
now. Oh my
with
God.
Dr. Basim.
This case come in UK only, and all failed in this case. No one knows this case.
Okay.
Cannabis induced vomiting?
What?
Cannabis induced vomiting? Cyclic
No.
vomiting?
No.
This is Dr. Sarah case. That's why she provided.
Dr. Mahmoud.
No.
Yes.
Keep it for after tomorrow. We'll
Dr.
do it.
Mahmoud, please,
Yes, Dr.
a humble request, Dr. Mahmoud. After succeed in your exam, inshallah, please continue with us here.
Sure, it is 100%.
Yes.
It is no.
Yeah,
this is special
it
request.
is only allowed one day, your day of exam. After that, be with us, please.
Okay.
No vacation, only one day vacation.
Yes.
Yeah, really, we
No
need
vacation.
you.
I will
need
enter
you.
on Saturday. Don't worry. I have a lot of
Okay.
cases,
Yes,
but this
yes.
case.
Thank you.
This
Thank you
case.
very much.
This case was interesting. One friend from UK told me about this. It is a surprise case, really.
Okay. Don't excite us more. Okay, we'll see it after tomorrow. But I will ask about.
ربطت الساعة على 11 بعد بكرة منبهين.
Really, it will be interesting. But
I have
Dr.
question
Hinde
for
is
this
the
case.
only one. She will know. Yes.
The driving was positive. He was driving, right?
Yes.
Okay.
He was driving.
It will affect the welfare. Yes.
Yes. So 6 months. 6 months.
No. It's provoked. No. It's
It
provoked.
is provoked. عليك
No.
نور. أنا هذا اللي كنت خايفة منه إنه whenever there is a provocation factor,
it will be
don't
temporary.
anticipate the duration. لأنه they might not
even
might not
be
span
involved
for the whole duration. ترى حتى في كيس كانت seizure لأنه انعطى البيشنت wrong dose of insulin. it was a seizure provocated by an error. فكانوا بدهم اياه للكانديديت يوقع بالغلط ويقول البيريود تبع 6 months. انت لازم تحوله على الدي في ال اي و they will consider the case و they will decide if they need to ban what are the criteria for how long. It's not you. they might not decide
Ban him.
on him for
Yes.
6 months because it's provocated. يعني if you correct الكالسيوم خلاص.
Yes, he can drive back.
But I think provocated Dr. Hind
No.
6 months and unprovocated 1 year.
No, provocated 3 months. Provocated 3 months.
Yes,
Unprovocated.
I think less half the duration of 6.
Yeah,
تمام.
3 and
First
6.
you have انت first seizure recurrent أعتقد ال first seizure 6 months ولو another attack for 1 year. هذا type 1 vehicle. type 2
1
vehicle
year.
1 year 5 years.
Yes.
إذا
Yeah.
مالي غلطانة. فيعني we should revise بس believe me if there is a provocating factor and correctable
Refer him.
provocating factor they will study the case. It will be an individual based decision by the DVLA.
Yes, agree. Yes. Well, Dr. Mahmoud, and nice to know. And also the last point, even
Yeah.
discussion was hot about driving and provocation.
Yes.
So your attendance is must.
Sure, Dr. Basim, 100%.
Dr. Basim?
Okay.
Yes.
Yes, Dr. Yes, Dr.
Yes.
Muhammad.
Dr. Basim, if the patient he has already has epilepsy and admitted in the hospital and missed the dose of antiepileptic medication and patient develop seizures, for how long this patient should be stopped driving?
هذا البيشنت
nothing.
epileptic. هذا epileptic.
Nothing.
هذا رجع ينطبق عليه كل القوانين تبع الإبيليبسي.
No.
صح نحن كنا السبب لأنه وقف الدراج بس he will have to be banned for another 1 year.
No, Dr. Hind. I don't think he will drive back after
لا
resuming
أنا
medication.
تذكرت السيناريو وكان كان
Yes, I think Dr. Basim it will be 1 year.
يس لأنه هو
I think
كان معصب إنه هلا أنتم بدكم ترجعوني باند فور 1
Yes,
year
that is the scenario.
وأنا كنت كنترولد. هذا السيناريو ما بنساه لأنه
With tramadol, I think it was with tramadol.
ترامادول وفي المست يعني في منه
No,
اللي إجا
I mean
وكان
miss
عنده
the dose.
procedure وكان لازم ياخذ الانتي ابيليبتيك والسيبس اوف ووتر ورحت الممرضه غلطت وانه هو مكتوب MBO فما عطته حتى الانتي ابيليبتيك. وفي تبع الترامادول كتير قديم بس الجديد تبع الميسنج دوز بيفور سيرجري بيفور بروسيجر كان لازم ياخده مع سيبس اوف ووتر كان اللاموتريجين اعتقد. فكان بصراحه ايرور جدا مؤذي لانه he will have now to be banned for 1 year.
Okay, Dr. Muhammad, want to ask Dr. Muhammad, go ahead. What's your question? Dr. Muhammad, you were asking while Dr. Hind was talking. Hello? You can hear us, Dr. Muhammad? Okay, so he will be banned again for 1 year, Dr. Hind?
he will be banned for 1 year لأنه خلص رجعت له السيجر. أنت فكرة
Yes,
أنت
uncontrolled. Yes.
عليك نور قلب uncontrolled. يعني هلا كل الجهد يلي اشتغلت أنت عليه 5 سنين ماضيين روحت له إياه بالميسنج دوز. Again his brain is firing. Again you need to modify his medication. ممكن حتى تبدأ دوز أعلى. فأنت بالنهاية صح it's something happened from your side بس physiologically his epilepsy now turned into uncontrolled.
Yes, and he should ask also for compensation.
He deserve. Yes, I agree with you. And all those things will be assessed by the social worker by the DVLA and he will be helped to find another job. All of these things he is eligible for them.
Yes. Thank you.
Dr. Hind, that you need to tell the patient for 1 year should be stopped or refer you.
انت you will tell him it might reach up to 1 year. Just not in order not to give a fixed frame. يعني
Yes,
you
yes.
don't know you don't know everything
Or
about
better to say I will
underlying
refer you to
epilepsy.
I will refer you back to the DVLA.
DVLA فهو
Yes.
ممكن يسألك لأنه هو سأل كان because he is educated لأنه
Yes.
جيت قبل هيك فهي said will they pan me like when I had my first seizure for 1 year. فأنت you will tell him that since you had a seizure now and your condition might turn into uncontrolled, it might reach up to 1 year, but I prefer that you get assessed by the DVLA and they give you the final decision about the period of panning. بس إنه أنا قلت لكم ليش عم بقول هالحكي لأنه بالنيو marking sheet it is written you should give a time frame ما عاد صاروا بيحبوا أسلوب إنك تتركها ضايعة، ما إنك بس هحولك على DVLA يلا روح هنيك بيقولوا لك. you should offer some knowledge، بس كمان you should offer some knowledge in a good يعني professional way. In a way أنت ما you didn't trouble yourself and at the same time you gave some knowledge to the patient. فأنا I know that it is 1 year it can with the patient know. You will tell him it can reach up to 1 year, but I prefer the DVLA to assess your condition. تمام, the neurologist and the DVLA to check and review your case, and they are the one who will give you the final decision. فأنت عطيت time frame وبنفس الوقت you didn't give a final decision وحولته على specialized people. That's it.
Okay.
But the most important thing here, Dr. Hind, is apologize and the incident report.
Yes, sure. It's yes, the error.
سامحني دكتور محمد، انت كمان انا لاحظتك عم بتقول شيء، بس انا يعني ما بحب اقطع سلسلة افكاري فما بوقف بقول شو كنت عم بتقول.
Dr. Muhammad.
I
Yes,
want
Dr.
to
Az.
add something.
Yeah, sure.
Regarding tramadol, I have guideline in front of me.
Yes.
Non-epileptic patient and got seizure with tramadol.
Okay.
Car 6 months, bus 5 years.
Oh my God.
Non-epileptic patient, and we gave tramadol and he got seizure. Then, according to guideline, he will stop car 6 months and bus
6
for 5
months.
years. But if a patient already having epilepsy and you gave him
1
tramadol,
year.
and if he got seizure, you can make it double. Car 1 year, bus 10 years. Bus 10 years.
The scenario was the patient was epileptic, and that's why giving tramadol was an error because it will affect the threshold.
This was a medical mistake.
Yes, definitely. Yes, you have to apologize. Yes.
Yes. And
Nice.
if the patient is non-epileptic and you give tramadol and patient develops seizure,
this
then it is the
considered
complication.
the first seizure for a new onset first seizure 6 months. But if the patient is non-epilepsy, if the patient لا هي تعتبر unprovoked قصدك إن عطيت tramadol.
Yes, provoked by tramadol, so it will be 6 months.
Provoked by tramadol, بس أنت يعني it's not reversible. Patient have a يعني أنت مثلا لو وقفت الترامادول طيب البيشنت still at risk of having seizure. بس لو أنت صلحت الهايبوكالسيميا البيشنت might not get a seizure. فالترامادول ما بيعمل لك seizure إلا patient have risk to develop. فهمت شو قصدي؟ لأنه هو بيلعب لك بالthreshold of already affected brain. بعكس الهايبوكالسيميا أو أنا لو عطيت يعني أنا لو شو قلنا الثاني تبع الهايبوغلايسيميا. الهايبوغلايسيميا شو دخلوا بالسيجر؟ انسى الهايبوغلايسيميا بس تبع الهايبوكالسيميا. فهدول يعتبروا provocation. فأنت لو حسنت الهايبوكالسيميا ما عاد you will not develop a seizure. شو قصدي؟ بعكس الترامادول أعتقد الترامادول is not يعني will stop for 6 months. أو ماني متأكدة، ممكن لا والله ماني متأكدة، بس I feel إنه الترامادول will not cause a seizure except in a person who have a risk to develop seizure and he might have it again حتى لو أنت وقفت الترامادول.
Okay. Thank you,
بس
Dr.
الهايبوكالسيميا is more benign cause يعني.
Yes. Obviously, yes. Okay, thank you, Dr. Azhar, as well, Dr. Mahmoud, for the case. A very hot discussion today about the case, about the driving, about the DVLA.
Yes, Dr. Basim, but please, Dr. Azhar, can you share the DVLA in the group, please? It will help me a lot.
I have it. I can
دكتور
share it.
محمد في PDF كامل أنت عن جد المفروض يكون معك، يعني هي من الأشياء اللي حلو تتراجع قبل يوم الامتحان. PDF كامل ابعت لك إياه في الكونديشنز ابتداء من السينكوب والفاسبريجل.
بليز دكتور هند.
خلص لازم تتصفح الفهرس والأشياء اللي متأكد إنه عن جد it's common تروح ICD. ما بعرف أنا شفتهم عم بيعملوا كتير سنين ICD بس ما بعرف إذا صار يجي بالامتحان. تفضل.
Okay.
It is long دكتور هند. How many pages?
لا انت اولا ما حتفوت عليه كله، انت المفروض من الفهرس فوق تفتح الفهرس وتحط صح اللي بدك تراجعه. يعني مثلا
The common scenarios.
ايوه الفازوفيجل، السينكوب، هن حيكونوا كتار، بس لما انت حتراجعهم الجداول جدا واضحة وجدا سهلة، هيك يعني لمحة سريعة، هون 6، هون 1، هون 5، هون 3 شهور. بس للأسف هو طويل، يعني انت لا تطلع على عدد الصفحات، انت شوف الفهرس وقرر شو اللي بدك تراجعه، وبعدين واحد مر عليهم.
اوكي
تمام.
دكتور هند.
بس لأنه بينسألوا LCC وبينسألوا بالكوميونيكيشن، فأنت مضطر TIA، الستروك، الإبيليبسي، السينكوب، الفازوفيجل، ICD. تمام. وكله أنت لما حتمر على الفهرس عن جد حتقرر شو اللي بدك تقراه يعني من الملف. تمام.
Okay.
حابعت
Yes.
لك إياه، حابعته على الجروب بإذن الله.
Okay. Thank you, Dr. Mahmoud again, and thank you all of you for sharing. And new candidate today, new voice, Dr. Muhammad. He shared with us also, and he requested special request from Dr. Mahmoud to be usual and always attendance. Hopefully he will be. Inshallah. Yes, inshallah.
Don't
Yes.
worry.
Inshallah, you will be welcome, Dr. Mahmoud, anytime.
Thank you.
Dr. Mahmoud,
Yes,
Mahmoud,
Dr.
as you
Yes,
told 5 causes of hypocalcemia, celiac, rhabdomyolysis, post-surgical, bariatric, parathyroid surgery. What was the fifth one?
Decrease oral intake, hypoglycemia, hypoalbuminemia,
post-thyroidectomy, post-bariatric, celiac, rhabdomyolysis, and tumor lysis syndrome.
tumor lysis, yes.
Tumor
Tumor
lysis.
lysis.
This the 5 cases came in basis.
Okay, thank you, Dr. Mahmoud.
Thank you, Dr. Azhar. Thank you very much.
Okay, thank you all. Inshallah, see you tomorrow with the communication. Any comment in the chat box? Sorry, I didn't see decrease. Oh, yes, the call. Thank you. Okay, no more comments. See you tomorrow, inshallah, with communication day. Thank you for the attendance. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.